Thank you. Thank you everyone for your patience and flexibility this morning. Our normal admin for the board was unexpectedly out sick and we could not log into the meeting. She was the host. So we have Michelle Hatfield helping us out this morning. Thanks, Michelle. And we sent out an updated Zoom link to everyone on the meeting appointment, as well as updated the Oregon Health Policy Board's website and meeting notice. So folks will probably be joining in over the next several moments as they read those emails that we sent out. But I want to introduce myself. I'm Tara Chetok. I'm the project manager for the Oregon Health Policy Board, and we appreciate you all being here for today's educational webinar on the interim evaluation of Oregon's 2017 to 2022 Medicaid waiver. Before we get started this morning, I just wanted to remind everyone that if you could please mute yourself, as well as if you ask a question, make sure that your phone and computer notifications are muted as well. That is helpful. We are recording today's webinar, so that will be available on the board's website, and it's helpful to not have those background noises if people are viewing the recording or listening live today. I just wanted to remind everyone as well that this is a public meeting. It is not an official board meeting, so no board business will be conducted. This is for informational purposes only. We're also asking that we hold all questions till the end of today's presentation. And without further ado, I'm going to introduce Chris Demars, who is the Interim Director of Delivery Systems Innovations Office and Transformation Center Director for the Oregon Health Authority, who will introduce this morning's presenters. Go ahead, Chris.
Thanks, Tara. So hi, everyone. Thanks for being here. As Tara just said, we're going to hear from OHSU's Center for Health Systems Effectiveness on their interim evaluation report of Oregon's progress on its 2017 to 2022 1115 demonstration waiver, which I'll just point out is separate from the current 1115 waiver renewal process we're going through, which would follow this current waiver. The evaluation report focused on integration efforts for behavioral health and oral health, changes for dually eligible beneficiaries, and spending on health-related services. And these evaluation aims were identified via feedback from a series of community meetings that occurred in 2015 and 2016. So for the report, CHSE staff performed an independent evaluation based on their assessment of data that they were able to obtain through a variety of methods. And OHA has had a chance to review the report for major errors, but CHSE is responsible for this evaluation. So now I'm going to introduce the presenters. They are the Center for Health Systems Effectiveness Director, Dr. John McConnell, who's a health economist whose research is focused on state health policy, behavioral health, and quality improvement. He currently leads studies on Medicaid payment and delivery systems reform with a focus on Oregon and Washington. In addition to assessments on overall changes in health spending and quality, Dr. McConnell his work includes assessments of specific interventions designed to reduce disparities, improve prenatal and maternal health, improve outcomes related to substance use, and address social determinants of health. And Dr. McConnell is joined by Jenny Grunditz, the Senior Research Associate at CHSE, which she joined in 2015. Prior to that, Ms. Grunditz worked on two economic consulting firms, where her health-related work included an analysis of hospital mergers and an assessment of the economic consequences of medical liability reform. Ms. Grunditz has experience performing quantitative analysis of data from a broad range of sources and drawing on multiple disciplines, including economics, finance, management, and sociology to solve complex problems. Her current work at CHSE focuses on healthcare performance improvement and Medicaid financing. So with that, John and Jenny, I'm going to pass it on to you.
Okay, thank you so much, Chris and Tara, for the introduction. My bio was a little bit slightly not up to date, but I have been in the last 5 years working on a number of evaluations of waivers and other Medicaid programs as part of my role at CHSE. So thank you so much for having us today. As Chris mentioned, I have John with me, and we also have Ashley Daly, who is our research statistician on our team. We're here, as everyone has mentioned, to present the findings and recommendations from the interim evaluation of Oregon's 2017 to 2022 Medicaid waiver. Next slide. And as you're probably aware, CMS requires that Medicaid waivers be evaluated by an independent external evaluator. And OHA selected the Center for Health Systems Effectiveness as the evaluator for this waiver. Our center has also conducted the summative evaluation of Oregon's previous 1115 waiver that went from 2012 to 2017. And we're also currently the independent external evaluator for Washington's waiver, the Medicaid Transformation Project. Next slide, please. So today we'll begin with an overview of the evaluation aims and the methods. We'll go through the main findings, and finally we'll present some recommendations. Before we start, though, I wanted to note that the findings and recommendations today that we present today are part of the draft interim report. This was sent to CMS in June of last year, or of this year, pardon me. And this report is currently undergoing CMS review and approval, so it's not yet final. And this report will be followed in September of 2023 by a summative evaluation report, which will include additional years of data. Next slide. Okay, so evaluation aims. I will start with talking about the goals of the waiver itself, which Chris mentioned briefly. The waiver aimed to focus on integration of physical, behavioral, and oral health care, address the social determinants of health, and improve health equity. There was also a commitment by Oregon to a sustainable rate of growth of costs, and also a commitment to expand the coordinated care model for Medicaid and Medicare dual eligible members. And these are members who are simultaneously enrolled in Medicare benefits and Medicaid, and represents approximately 13% of the OHP population as of 2019. And so the report aims follow from the aims of the waiver. I'm presenting these here in order of the presentation today, not necessarily in order of how they're presented in our report. So the first aim is to assess progress on integration of physical and oral health. The second is to analyze adoption of health-related services. Thirdly, to assess progress on integration of physical and behavioral health. And then to examine CCO enrollment and outcomes for dually eligible Medicare Medicaid beneficiaries. Next slide, please. So a little bit about the study methods. Our main method here is analysis of claims data. We use data from 2011 to 2019 to calculate outcome measures for oral and behavioral health integration. And then we also look at outcome measures for dually eligible members using data from 2013 through 2018. And I should just note here that all of our data, actually I will note that at the end. I should also add that our analysis includes review of CCOs Exhibit L health-related spending reports that are submitted to OHA on an annual basis. And we also conducted a series of interviews with CCOs on HRS adoption. And we had a total of 12 interviews and 34 participants in total. And our key informants had diverse roles within CCOs, including CEO, CFO, medical officers, and staff members that were working in different capacities in community engagement, finance, health equity, and other positions. And so just to clarify, I just want to note that we're using pre-COVID data for this analysis and the results that we're presenting here. This is all data through 2019, with the exception of the interviews that were done in 2020. So we're not able to say very much at this point about the impact of COVID-19 on the outcomes under the waiver. Next slide, please. A little bit more about the claims data analysis. Firstly, we looked at the adjusted change in outcome measures from 2016 to 2019 and from 2011 to 2019, controlling for members' demographic characteristics. Secondly, we analyzed the performance by subgroups based on age, gender, geography, disability, and chronic condition. And thirdly, where possible, where we had the data, we compared changes for focus populations to changes for reference populations. Focus populations were defined in collaboration with OHA's health analytics team as children and members whose primary language was not English. And we used a difference in differences model to compare the 2016 to 2019 change in the focus population to that of the reference population. Next slide. And I've already mentioned this, so I'm going to skip this slide. All right, so on to the key findings. I'm first going to talk about oral health integration results and show some highlights from that analysis. Then I'll talk about health-related services findings. And after that, I'm going to hand it over to Dr. John McConnell, who is going to talk about behavioral health integration, pardon me, and dual eligible members. And we'll also run through some of the limitations of our analysis. Next slide. So for oral health integration, our key findings on the quantitative side, now we didn't do any interviews relating to oral health services, so this was all quantitative results. Our measures of oral health quality, access, and integration generally improved. We saw a continued decline in ED use for non-traumatic dental visits, dental conditions. So these are things that are not, or potentially could be treated outside of the emergency room in an outpatient setting and avoided through preventive care. And we also saw an increase in spending on dental services outside the ED. And part of this was due to an increase in reimbursement rates that happened in 2018. And the next slide. A few highlights here on access and utilization measures for oral health. On the left, we have the percentage of members that access dental services between 2011 and 2019. And on the right, we have the number of visits per 1,000 members. And the blue line here shows all dental procedures. The orange line is for core dental procedures, which is a subset of 14 common dental procedures that includes oral exams, fillings, x-rays, crowns, etc. And the idea here is to look at a fixed set of procedures over time so that we control for any changes in the types of dental services that are being accessed and provided over time. So generally here for both the access and utilization measure, you can see a dip in 2015. But then after that, we have a steady increase in both access to dental procedures and number of visits from 2015 and onwards. Next slide. And then this shows the ED visits for dental conditions. On the left, you can see the ED visits for traumatic dental conditions. These are already very low, but they have sort of plateaued out starting in 2016 and are sort of flat at about 2%. Or 2 visits per 1,000 members. And on the right, we have ED visits for non-traumatic dental conditions, which are continuing to drop throughout this waiver period. So that is a positive outcome. And then the next slide, please. So this slide shows some results for children versus adults. And this is for the analysis I was talking about, where we did a difference in differences model to compare the change for children to the change for adults between 2016 and 2019. So on the left, you'll see the percentage of members that access dental services, and on the right is the number of visits for dental procedures. The top line, you'll see the change for children between 2016 and 2019. The circle is the 2016 value, and the solid dot is the 2019 value. And so for percentage of members accessing dental services, you can see that the increase was larger for children than for adults, and the same goes for the number of visits. Next slide, please. This slide shows some data on spending on dental visits. On the left, we have spending on ED visits for dental conditions, and that's sort of similar to the utilization metric I was showing earlier. That's sort of flattened out. On the right, we have spending per member per month on dental services, excluding ED visits. So these are office visits and other preventive care visits, which have that spending is sort of fluctuated a little bit more. We saw an increase in 2018, which was to be expected because of an increase in payment rates for dental services. Okay, and so I'm going to move on to health-related services. And before I talk about health-related services, just recapping that as part of the previous waiver, the state introduced flexible services, which are low-cost services that are not covered under OHP, but that would promote health and potentially replace the need for medical care. These are things such as bus passes, meals, classes on pain management, air filters, other items for the home. Those are just some, a few examples. And so CCOs were able to spend on those types of things under the previous waiver. However, spending was inhibited by a number of things, including there was some confusion over what was allowable, how the spending would be treated, whether it would be treated as administrative or medical expenses. And there were also some concerns that spending on flexible services would lower capitation rates for CCOs. And so the 2017 waiver sought to address some of these concerns. And firstly, Oregon renamed this category of spending to health-related services, which included flexible services and community benefit initiatives. And community benefit initiatives are community-level interventions focused on improving population health. And they could also include expenditures related to health IT. So with that new definition, there was a significant expansion of the range and size of investments that could be counted as health-related services. There was also some, as part of the waiver, there was also clarification around the treatment of health-related services in the medical loss ratio, and clarification that these could be counted as medical expenses in calculating the medical loss ratio. There was also clarification that health-related services could count toward rate development. And OHA provided a lot of technical assistance to CCOs throughout the waiver period, or throughout the at least the first 3 years that we've studied, about how to use health-related services, issued a lot of guidance on how to do that, and how to comply with the requirements for health-related services. They also promoted health-related services as the primary strategy for addressing social determinants of health at both the member and community levels. And there was also a discussion, and through the Medicaid Advisory Council, there was an identification of housing-related services and supports as being a key priority. So I'm going to move to the next slide. The key findings on the quantitative side here are that based on our analysis of Exhibit L spending data from these reports, spending increased between 2016 and 2019 from 7.2 million to 16.2 million. As of 2019, though, health-related services remained a small share of total spending on member services at approximately 0.36%. I want to caveat, when looking at trends over time, there were some limitations in the health-related services spending data due to changes in reporting requirements over time. There were also some gaps in reporting where some CCOs didn't report any health-related services in some years. And in 2018, OHA began to undergo a more kind of more of a formal approval process for health-related services. And so a lot of CCOs, or a number of CCOs, had expenses that they reported that were not approved as health-related services. So it's tricky to make year-to-year comparisons here, but we will do so nonetheless. Just keep that in mind. And so the last point I wanted to make is that there was a lot of variability between CCOs in their health-related services spending, both in terms of the types of spending and the amount of spending. And for one, when we talked to CCOs, we understood that they were at varying stages of implementation of their health-related services program. So that accounted for some of those differences. Another reason that was cited was that CCOs were sometimes funding these programs through other sources. So they may be funding community level interventions using earnings from their quality incentive metric scheme, for example. So this shows the total health-related services spending between 2014 and 2019. And looking at this particular waiver period, you can see from 2017, we have an increase, substantial increase in health-related services spending. We see that a significant part so I think I should back up here and say that overall, key informants that we talked to found that, or said that the waiver made it easier for CCOs to prioritize health-related services spending, easier to justify those spending decisions to leadership and so on. So clearly that was a success. A significant part of the growth in health-related services spending also reflected the fact that, as I've discussed, CCOs were able to categorize, they were able to include community level interventions and health information technology spending in health-related services. And so that meant that they could categorize some of their existing programs that address social determinants of health as health-related services under the expanded definition. And in interviews, actually, sorry, back up again. In interviews, CCOs noted that they had already made some significant investments in addressing social determinants of health in their communities. And with the new guidance on health-related services, they aim to fit most of that social determinants of health spending into health-related services requirements. So, and then the last point I wanted to make about this chart is just that we see that most of the increase from 2018 to 2019 was health information technology spending. And that was beginning in 2019, that was required to be reported as a separate category. And previously it was included as part of community-based initiative spending. So there certainly was some HIT spending prior to that, but we just aren't able to break it down. Okay, next slide. And so this shows the health-related services spending by CCO and by type. And here we can see that overall across CCOs, the orange bars here are community benefit initiatives, and those were the predominant types of health-related services spending across most CCOs in terms of per member per month spending. There was one CCO that spent the most of its funds on health and information technology. We heard in interviews that CBI, or community-based initiatives, frequently involved funding community nonprofit organizations to address various priorities related to social determinants of health, including housing, food security, care coordination, and so forth. Next slide. Here we have looking only at flexible services spending, so only spending for items for individual members. Here, housing was the largest expenditure in both 2018 and 2019, growing from about $77 to $92 per 1,000 members per month. And all other big categories were transportation and training and education, and the transportation excludes non-emergency medical transportation, or NEMT. Next slide, please. Oh, yeah, that's the last one. Yep, you got it. So qualitative findings, I've already kind of interspersed some of those here when I've discussed the data, but overall, we learned that health-related services has been helpful in responding to COVID-19 and the 2020 wildfires. Part of the reason was that there was already infrastructure, relationships, tools that had been built for health-related services that could be applied to the COVID-19 and wildfire response. It was also clear to us through the interviews that health-related services requires a lot of new relationships, investments in data and tools, and these include systems for data collection on social needs, data collection on subgroups that are experiencing inequities. There needs to be the ability to store and share that data through warehouses and platforms, and there also needs to be partnerships and contractual relationships with community-based organizations and local agencies, providers, and the broader community. Another thing that is required is a capacity to track, to some extent, to be able to track outcomes and to report health-related services spending. Sort of related to that, CCOs generally said that they were challenged by a high administrative burden for tracking and reporting data on HRS. And we are, however, aware that the state is currently doing a lot of work to streamline health-related services reporting. And a last point we wanted to make was that sometimes CCOs opted to spend on social determinants of health, but did not report this as health-related services, partly because of the cost of reporting. And so that was the last slide I had, and I'm going to hand it over to Dr. John McConnell.
Great, thanks, Jenny, and thanks for the opportunity to talk to you today here. As a reminder, what we're looking at are really 4 outcomes. And so you heard from Jenny on oral health integration and health-related services, and I'm going to cover behavioral health integration and changes to the duly eligible Medicaid and Medicare population. With respect to behavioral health integration, so this behavioral health integration means bringing primary care and behavioral health care closer together, both at the delivery system and at the financial payer level. And we've seen a lot of progress to date. This is a priority when the CCOs launched. Some of the investments in the patient-centered primary care home have been designed to facilitate integration. There's been a lot of support, models, information coming out of the Transformation Center. The state has a information exchange, ED and pre-managed, that allows physicians to get a better track on the clinical records of their patients, even if they're not specifically at their clinic. This allows for understanding what happened in an emergency department that maybe isn't part of your hospital system. The state was part of a national demonstration project that not all states took part in, but Oregon did, in terms of trying out certified community behavioral health clinics. These are designed mostly for patients with serious mental illness. There's 12 clinics at 21 sites. And in the new CCO 2.0 contracts, the state specifically disallowed a subdelegation of behavioral health. What that means is that we all know that CCOs get global budgets. In the past, there were some instances where even though the CCOs got a global budget, they tended to subdelegate or carve out the behavioral health or mental health benefit to a third party. And we think that that created some opportunities for things that didn't really look like true integration. This is an improvement. I think there's still some areas where there's a little bit of separation happening among some of the CCOs, but this is a movement in the right direction, we believe. Next slide. So I'll show you a variety of graphs. You can look at the report for more information. These are really, we don't have a great comparison group, so a lot of this is just sort of looking at trends over time. It gives us some idea of what's happening. Our findings here are generally mixed. We see some measures improving. I'll show you what those look like. We see some quality measures remaining unchanged. We see some increases in the number of enrollees diagnosed with substance use disorder, but not necessarily increases in the percentage of those individuals who are getting treatment. And we see expenditures going up for individuals with behavioral health conditions. Next slide. So here's one example of a metric where things seem to be trending in the right direction. So we have emergency department utilization for individuals with behavioral health conditions going down. That's both overall ED utilization on the left, and then a measure of potentially avoidable ED visits, which could be more sensitive to access to care. That is also dropping, and those are good signs. So that's dropped since 2011 down through 2019. Next slide. Here we see changes in prevalence of substance use disorder among Medicaid beneficiaries. And so this has really increased a lot since 2011, going from under 3% to almost 9%. I think there's a couple ways to look at that. One is that could be an increase in screening, which would be a positive. This could also just represent general increases in prevalence of SUD in the community or within Medicaid beneficiaries. So that's, I don't think there's sort of a positive or negative to put on that. Unfortunately, we don't see large increases in treatment. And so the graph on the right shows initiation of alcohol or other drug dependence treatment. And that has been relatively flat over the last, from between 2011 and 2019. Next slide, please. Here's some measures of utilization and expenditures. Outpatient visits for behavioral health care have gone up, and especially they kind of were coming down between 2011 and 2016, but have gone up since 2016. I think that's generally a good sign. Behavioral health expenditures were flat between 2011 and 2014, but have begun to creep up. This is, I think this could be a plus minus on one side. If this means better access and better outcomes for those individuals, that's probably good. On the other hand, we're all aware of the 3.4% spending growth target, and so we want to be wary of large increases within any group. Next slide. So those are some quantitative findings, which I would sort of characterize as generally mixed. Some good things, some things that don't look like they're moving quite in the right direction. On the qualitative side, I think we did see a couple areas that maybe suggested that the focus on behavioral health and behavioral health integration could use some more attention. And I'll start with sort of the lack of publicly available information, and kind of the first place that people might go, including researchers, but also patients or clinicians, would be what is the state's stance on behavioral health integration? And at the time when we did the report, it was really hard to find much there, and hard to find much in terms of what was meant by integration. And so I think we all agreed as a state that integration was important, but there wasn't a lot of clarity on how that would be defined. And I contrast that to the state of Washington. It's also focusing on integration in their Medicaid program, and they have specific models for primary care. And so they've advocated for a model called the collaborative care model to be taken up by primary care clinics, and they're pushing that out, and they're measuring that uptake with some specific tools. They have a separate model for clinics, mental health clinics, and how those mental health clinics should integrate primary care into the mental health clinics. So a lot more definition there and a lot more understanding of where that's happening. And that was hard for us to assess here. And so I think that was one area of concern. Also, kind of a lack of clarity about what the roadmap was, some missing definitions, not clear sort of what the ultimate goal was or how care would look different in, say, 2 years or 5 years. And so we came away with sort of a sense that people agreed on integration, but there was some weaknesses in terms of how that had been vaguely defined, and it wasn't clear what populations it referred to. And so, for example, we might expect that primary care integration is particularly useful for individuals with mild or moderate mental health, but integration in the mental health clinic, bringing in physical health care, that might be particularly important for individuals with serious mental illness. Those are two different things. We didn't see a lot of definition on that. There's a lot of initiatives that are happening. And I think that you saw some of this. Actually, I do want to sort of caveat all of this. I think that the Health Policy Board saw a presentation from Steve Allen, who's the new director of behavioral health last week. I looked at those slides, and I thought that this was sort of that was a really great set of slides that respond either purposely or indirectly to some of the concerns we had. And so what I saw there was starting to map out priorities and a roadmap, and I think that's the right direction. If you looked at those slides, you saw a lot of initiatives. I think when we were doing our report, it wasn't clear whether they were being coordinated or if everybody was talking to each other. There's a large substance use disorder waiver that the state is planning on targeting. There's the community mental health clinics that is part of the demonstration project. There's a variety of others, and they don't necessarily all fit together. It's not clear that everybody knows what everybody else is doing or how they should be prioritized. I think that's a concern. And as I mentioned before, sort of a lack of clarity about what the end state would look like. So I think we came away with some concerns about some more attention here needed. And I think that what I saw on the slides last week really speaks to that. So that's a positive development. Next slide. So now I'll talk about the dual eligible members. Next slide. So as a reminder, the dual eligibles, these are individuals in Medicaid who receive their coverage through a combination of Medicare and Medicaid. There's always been historically a nationally concern about the care that these members have been getting, concerns that fragmentation could arise from different insurance groups. Oregon's approach beginning in 2012 with these individuals was that they would be in the fee-for-service system, but they would have the option of opting into a CCO. Beginning in 2019, that's flipped. So they're automatically rolled into CCOs, but have an option to opt out and be in the fee-for-service program. The data that we have for this don't bring us up to 2019. And so what I'll just show you are some trends leading up to there. And the upshot of this is there are no large changes observed from 2016 to 2018. Next slide. So here's some data. You can see that the number of Oregon dual eligible members enrolled in CCOs went up a little bit between 2013 and 2015, and that's been really relatively flat. The number who get any primary care has been pretty flat between 2013 and 2018. Next slide. Spending for these individuals went up a little bit between 2013 and 2015, relatively flat since then. Next slide. So that's all I'll say about the duals, and we'll have more to say when we get more data. Let me talk a little bit about some of the limitations for the results that Jenny and I have shared with you. Next slide. So this is really a broad assessment, kind of looking over time across the state. There may be really nice models within different CCOs or specific practices or approaches that are really promising. We didn't get down to that level. We understand that health equity and understanding disparities is a priority for the state. We didn't do any of that work because we didn't have high quality data on race and ethnicity, so we didn't do any stratification there. That's a limitation. Most of this work looks at metrics on data that occurs before the CCO 2.0 era, and we know that's an important change that's not picked up in this study. Our spending measures rely on something we call imputed prices, and this is a technical issue that's with more detail provided in the paper. But essentially, there's a few different ways that providers can get paid. Not all of those show up perfectly in the data that we have, and so we did some work to average up from that. That's a pretty standard process, and I think gives us directionally the right results, but is one limitation that should be mentioned. And as I said, there's some technical details there that we can talk about later. I can refer you to the report. And we know that there's some inconsistencies in how the health-related services spending data were entered there, so we don't have true apples to apples comparisons across CCOs or over time. Next slide. Okay, moving on to recommendations. Next slide. So I'm going to flip the order that we talked about these. And so I think what you heard kind of coming through the aims was first about oral health, then health-related services, behavioral health, then dual eligibles. I'm going to flip these in order so where I think we've got the most to say about them. And so dual eligibles, so we don't have information since the policy change. Our recommendations here are sort of light. We want to use data from 2019 and on to assess the impacts and monitor, and that's an obvious one. The other one I think we'll be looking at is understanding enrollment and outcomes for CCOs that may also carry risk for Medicare Advantage. We saw some early signs from data previously that CCOs that had Medicare Advantage and the Medicaid plan were financially at risk seem to be doing a better job in terms of better quality for those members and also controlling cost. And you can understand intuitively why that might make sense. I think a more robust assessment of that would be helpful going forward. Next slide, please. Whoops. 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 Oh. And okay. Oh, let's go to oral health integration. There we go. Okay. So this one, I think we're still, we saw some promising results here. I think there's some changes that are still coming out. We'd suggest that we build on this apparent success. I think we're seeing some increases in access, which is good. We understand there's a new dental director coming in, or maybe they've already arrived, and we suggest that they be empowered to strengthen communication and coordination across OHA. And putting forth a strategic plan and vision, I think it's really helpful to understand what the future state should look like. Next slide, please. Health-related services, I think some of this work is already underway, but our recommendations are to refine guidance on reporting of HRS expenditures to promote consistency, to monitor the administrative burden. We heard from some CCOs that it took an extra person or FTE to figure out how to enter these data to make sure they were consistent, make sure that they were entering it in a way that was a little bit different than some of the work they'd done before in terms of entering medical claims, and we don't want that administrative burden to become too large. It will be important to develop an evidence base for investments in social social determinants of health. This is a really critical area for Medicaid in the states, but I think there's still, we still need more evidence on when these interventions work and for what populations and how they should really be targeted. And I think we need to understand where CCOs are limited in addressing social determinants of health. And so one thing that we heard from some CCOs is that they were really interested in the houseless population and addressing some of those issues, that they had some tools from flexible services or health-related services that would allow them to make changes, but the fundamental issue was housing shortages, and that was something that they had trouble connecting with. And so being aware of where those forces outside of the CCO's control may be affecting outcomes will be important. Next slide, please. The last one is around behavioral health integration. I think our feeling in working with this report, this is the second to last one. Sorry, I got one more after this. I think working on the report, this was one where we felt like it was hard to get a sense of what the state's vision was. And I think my opinion on that has changed. I see development based on the report from Director Steve Allen that put out last week. I think that's a movement in the right direction. I think it'll be helpful to clarify accountability for behavioral health, including coordination among multiple initiatives. There's a lot of money coming into the state. In some ways, this may be kind of a one-time bolus of funds to really attack some of the most critical issues that we see across the state. And I think we want to do our best to do right with those funds. But that will take some organization. We can't expect these things to succeed in fragmented ways or when they're siloed. And I would advocate for considering the needs of different populations, including children, adults, individuals with serious mental illness versus those with more mild or moderate conditions, and communities of color. These all need slightly different approaches, or maybe very different approaches. And my feeling about the way that some of the language around integration was rolled out in the past was that integration was treated in a somewhat vague way without a lot of specificity as how it might look different or should look different for some of these populations. Next slide. Final recommendation, we have a couple things to mention around health equity. First is to provide some guidance on terminology. And so at various points in time, we've heard different terminology: social determinants of equity, social determinants of health and equity, health equity. These sort of changed a lot as we were writing the report. And I think that created some confusion and probably a lot of extra work. I think that getting everybody on the same page about what the right terms are, that will help move the conversation forward. There'll be less confusion around what do we mean when we're using one term or the other, which one should we use. I think that's happening, probably already has happened. And then finally, we need better data on race, ethnicity, language, and disability. CCOs need to be supported in collecting that real D data, and then we should monitor the percentage of members for whom data are collected. There's a large amount of missing data, or there was historically. We'd like to improve that. I think that is my final slide, and Jenny and I would be happy to take questions now. Thank you.
Great. Thank you so much, John and Jenny. We really appreciate that. It's great information. Let's go ahead and open it up to our board members here on the educational webinar first, and to see if any of the members have any questions for our presenters or the OHA team, or any thoughts or comments. So we'll start with the members, and you guys can go ahead and you raise your hand or just unmute, or if people have questions as well from the audience, you can raise your hand or send your question in chat. Good morning, David.
Thank you for Jenny and John for a great presentation. It's fabulous. We really appreciate your time and sharing your expertise. John, what would it take to get good race ethnicity data so you could look more into health equity and disparities across subpopulations?
Well, I think that this is being collected. There's and I think somebody else at OHA can tell you what the status of this is, but I think there's a desire to sort of create a registry of the real D data for Medicaid beneficiaries. Historically, that was collected kind of on enrollment administratively, and that the sort of the missingness of that really got quite extreme beginning in, say, 2016. I don't know if somebody here at OHA wants to step in and tell David about the status of the real D data and how that applies to Medicaid, because they'll be able to speak to that better than I can.
Stacy, are you?
Can you hear me?
Yes, we can hear you.
Okay, sorry, I was double muted. Yeah, thank you, John, for starting that response. So I won't get into the deep details of what's going on with the REAL-D data, but I just do want to say that the one system, which is the front end for how data are collected on Medicaid beneficiaries at enrollment, is REAL-D compliant in terms of the way it collects data. A challenge exists, however, with the way that the data are what's called extracted, transformed, and loaded, or ETL, for those of you who are in the database world would call it. It is the ETL from the one system into the MMIS system has some challenges, and there are a wide variety of reasons for that problem. Won't get into those, but essentially we're working on an interim way to pull the data directly out of the one system, so bypassing the MMIS ETL that happens, and at the same time that we're pulling data from the one system, backfilling with some other data systems that we also have access to get to a higher completion rate. Because one of the tenets of REAL-D is that people cannot answer if they choose to, but of course OHA does have access to REAL-D information from other data sources for a wide variety of people, not just Medicaid beneficiaries. And so we are working to knit all of these data sources together and be able to, for Medicaid beneficiaries, we can actually get to about 97% completeness. We've done this on a provisional basis so far. So we've done a pilot of pulling these data together. The challenge is that to do this on an ongoing basis will require some dedicated resources and many people besides just Dr. McConnell and his team will want access to the data within OHA. So we need to have a whole process for governance of that data, how it's used, how it's produced, a place to actually store the data, a method for matching to other data sets. So it's kind of an operational issue at this point. We need to figure out how to operationalize this interim solution that we've come up with. And I do want to mention that this is work that Health Analytics has been doing hand in hand with the Equity and Inclusion Division for, honestly, it's mainly during the pandemic we've been working on, so it's gone a little bit more slowly than we would have chosen, but that's what's happening right now.
Thanks, Stacey. I just think it's with the governor's focus and OHA's focus on health equity, this is a really important investment well needed. And also, just one more comment. I see John has a question. I'll hand it over to John and others. I understand from John's presentation that this requires investment in CCOs to manage the social determinants of health data. I also think that is a very important investment. If that requires an extra FTE per CCO, I think that's a great use of money because we're going to learn so much from this data. And I think we're going to see how health outcomes are impacted by these investments. Determining how health outcomes are impacted by these investments is so important. So I just want to encourage OHA and the CCOs. Thank you for making this investment. Keep on going. And it's really important work. So thank you.
Great. Thanks, David. Thanks for bringing that up. We're actually working with some of the REAL-D subject matter experts to have a future educational webinar on REAL-D and the collection from OHA and how that's going. So we're hoping to roll that out this fall. So thank you for the question. I know Oscar Rana has to log off. I just checked with him. He doesn't have any questions or comments, but thanks the presenters for today. So let's go ahead and go to our next member, John. Looks like you have your hand up, John.
Yeah, thanks, John. Yeah, very thought-provoking work. Jenny and John, really thoughtful work. Two things. My recollection was one of our priorities in this waiver were children. And so it was nice to see that data around children when it came to oral health. But the degree to which I think you could do that in any area you look at and provide a sense of, well, how children fared when it came to behavioral health integration or other sorts of things, I think would be consistent with that priority we had. And I think we would hope to see the same thing as in oral health, because there was quite a bit of focus on children 5 years ago in the run up to the waiver. Then the second is I think perhaps related to some of the discussion that just occurred. To what degree can we separate out the Medicare population that has Medicare because they're disabled? So they're not over 65, they're under 65 and disabled. And get some sense of how the disability subset is doing. Because I think that would be informative. So those are my 2 comments.
Yeah, thanks, John. I think I wasn't able to pull it up quite in as quickly as I should have, but I think we just showed you sort of a brief take on this. I think we did address some issues around pediatric health in the behavioral health chapter. And so some of that is in the larger report, and I just wasn't fast enough to kind of pull up and give you a summary. So that's one response. I think that's a great question about separating out the individuals who are eligible for Medicare for reasons other than old age. And I think I've seen other studies that have really identified that those are quite different individuals. That we know that they have a high degree of disability, but also there's a large many individuals with high degrees of mental health conditions. And so I think that would have to be something we'd have to negotiate with the state, but it's a great point.
Great, thank you.
I can add to that briefly. Just a couple of comments. Yeah, we did just do a quick check on the portion of our dual eligibles in our data that were eligible due to disability versus old age. And we saw that about 60% of that population was eligible due to old age, and the remaining 40% was eligible as a result of disability. So they're both very significant groups, and that's a distinction that would be really interesting to look at, but it wasn't part of our evaluation design. So that would need to be a discussion that we would have with OHA, as John said. And then for children, yes, I agree. And I think there are, as John said, there's some more data in the report. You'll see some analyses by subgroups where we have for looking at results specifically for persons under the age of 18. However, some of the outcome measures that we use for behavioral health integration are by definition are only defined for people who are 18 or older, or in some cases 13 or older. So in that case, it's unfortunately not possible to look at children. So those are the couple of things I wanted to add.
Thanks for looking that up, Jenny, and providing that information. It's very helpful. Kristen, I see that you are showing your camera. Did you have any comments, Kristen? No, you're good. Okay, we have about 5 minutes left until we wrap up. I just want to welcome if there are any questions from our participants or comments from the OHA team working with Jenny and John before we wrap up. I'll just give it a minute. And I know John and Jenny, or Jenny, you shared at the beginning, but for some of the folks that may have joined late, what are kind of like the next steps and timeline with the evaluation being available?
Great question. So as I mentioned, the report is currently with CMS and is being reviewed. The last I heard was nothing has been heard back from CMS yet. It was submitted in June. So I think OHA and we are waiting to hear if there are any comments from CMS, but assuming that there won't be any major comments, I think The goal is to finalize this report and have it be publicly available by the end of the year. And OHA, please correct me if I'm wrong on that. So that's this interim report. And then we have our next report, which will be completed in September of 2023 and submitted to CMS for review at that point. And that will include 2 additional years of data. So here we only have 2017 through 2019. The summative report will include data through 2021. And we'll essentially be looking at the same outcomes and the same sort of evaluation design, just using additional data. We may have some differences in terms of additional analyses, depending on what we determine would be useful for OHA and for others. Thank you.
Great, thank you for adding those details. And I saw some head nods from Stacy, so it looks like that was all correct. All right, I just, for those of you that joined us late, I apologize about that. We had a last minute change with our admin host, but the recording of the entire educational webinar will be available on the board's website either later this afternoon or in the morning. So please go back and watch anything that you may have missed. And I'm not seeing any hands raised. I'm not seeing any chats in the chat box. So I think we're going to go ahead and wrap up. Thanks again, John and Jenny, for joining us this morning. We really appreciate it. And we look forward to the continued work on this evaluation.
Thank you.
Have a nice
Thank
day,
you.
everyone. Of course. Bye, everyone.